Hello everyone. Am I live? A very good evening to all of you. Am I clearly visible, audible to you guys? Let me check if I am clearly visible, audible. I will start the class ahead. Give me a minute to confirm. So yes, I hope it's working. So a very good evening to all of you. I welcome you all for today's session. I am Dr. Priyanka Sachdev here, and today I am here to take a very important topic from hematology here. That is leukemias and lymphomas. So in hematology, this topic is really very difficult to understand, and students find this topic very difficult. So here in this topic, I'm going to teach you four types of leukemias, that is myeloid as well as lymphoid. In the myeloid leukemias, I will be teaching you AML and CML. In the lymphoid leukemias, I will be teaching you CLL and ALL. So basically, I will be teaching you all type of leukemias in this session, the basic four type of leukemias. Then I will move towards lymphomas. In the lymphomas, I will be teaching you the two type of lymphomas, Hodgkin's lymphomas and non-Hodgkin's lymphoma. So this is a marathon session. It will last for the next 2-3 hours. But in the next 2-3 hours, we will be finishing entire leukemias and lymphomas. So stay connected with me. So let me start. So I will be very crisp and specific, right? So let me start with leukemias first. Okay, you know how many types of WBCs are there in human blood? In human blood, there are 5 types of WBCs. Basically, I can say 2 types of WBCs. The granulocytes, which have granules in the cytoplasm, and agranulocytes, which do not have granules in the cytoplasm. Now, the one which have granules in the cytoplasm are of 3 types: neutrophil, eosinophil, basophil. Neutrophils have purple color granules in the cytoplasm. Eosinophil have brick red color granules in the cytoplasm, and basophil have deep black or blue color granules in the cytoplasm. Coming on agranulocytes, which do not have granules in the cytoplasm, they are monocytes and lymphocytes. So total 5 WBCs are there. You can see the 5 WBCs in this diagram. Can you see this is a neutrophil? Can you see this is a eosinophil? This is a basophil. So see the granules in them. Can you notice? Neutrophil is also known as polymorph. I guess everyone knows it. So you can see the purple color granules in the cytoplasm. Appreciate the purple granules here. Appreciate the red granules in the eosinophil, and appreciate the deep blue or black color granules in the basophil. Appreciate these two cells, lymphocyte and monocyte. These two are agranulocyte. So these are the 5 type of WBCs. Now how WBCs are formed? All the 5 WBCs are formed in the bone marrow. The process of formation of blood cells in the bone marrow, that is RBC, WBC and platelet, is known as hematopoiesis. So basically, can you see a bone marrow in this diagram? In the bone marrow, the first cell which gives rise to all cells is the hematopoietic stem cell, the father of all cells. So hematopoietic stem cell, from the hematopoietic stem cell, 2 type of blasts are formed. It is normal mechanism. I am not teaching you currently leukemia or lymphoma. I am teaching you normal hematopoiesis, normal granulopoiesis, how WBCs are formed in bone marrow. Because if you want to understand the leukemias, you must understand how normal WBCs are formed in bone marrow. Then I will tell you where is the abnormality, where is the mutation, and how does it leads to leukemia. So before understanding the pathology, understand normal physiology, right? So in the bone marrow, the first cell is hematopoietic stem cell. From the hematopoietic stem cell, one myeloid cell, myeloblast is formed, one lymphoblast is formed. Now, as I have told you, there are 5 types of WBCs. The 3 are granulocytes, that is neutrophil, eosinophil, basophil, and 2 are agranulocytes, that is monocyte and lymphocyte. So total out of 5 WBC, these 4, all granulocyte and monocyte, these are myeloid series origin. They origin from the myeloblast, and the last one, lymphocyte, it origin from the lymphoid series. This is normal, right? So in all of us, in a normal healthy individual, the lymphocytes arise from lymphoid series and all other WBCs arise from myeloid series. So what do you mean by that? You can see here in this flowchart also, I have shown that from the myeloid series, all of them are arising, but from lymphoid series, only lymphocyte is arising. So you can see there are 2 type of blast, myeloblast, lymphoblast. So what I mean is that myeloblast give rise to neutrophil, eosinophil, basophil and monocyte, and lymphoblast give rise to lymphocyte. In this way, 5 WBCs are formed in the bone marrow. You got my point? I'm repeating again for those who have any confusion. So this is the bone marrow. Inside the bone marrow, the first cell is hematopoietic stem cell, who is the father of all cells. From hematopoietic stem cell, 2 blasts are formed, myeloblast and lymphoblast. Now the cells which are derived from myeloblast will be myeloid origin, and the cells which are derived from lymphoblast will be lymphoid origin. So basically there are two origin of cells in the bone marrow. So there are 5 WBCs. Out of the 5 WBCs, the 4, that is neutrophil, eosinophil, basophil, that is 3 granulocytes, and one of the A granulocyte, that is monocyte. They are derived from myeloid series. Only lymphocyte derived from lymphoid series, L for L, right? So this is the basics. I guess you understood. Now you have to tell me the intermediates in between. It is not that myeloblasts directly get converted into these cells. It is not that lymphoblasts directly get converted into these cells. So you have to tell me the complete series of the intermediate. Let's talk about the intermediates of the neutrophil. You have to understand the intermediates. So first cell is myeloblast. Myeloblast give rise to promyelocyte. Promyelocyte give rise to myelocyte. Myelocyte give rise to metamyelocyte. Metamyelocyte give rise to band form. And ultimately band form give rise to neutrophil. So I am teaching you how neutrophil is formed. Now in the same way, eosinophil, basophil and monocyte are also formed. Don't learn the precursors of them. The most important is neutrophil, right? So this side we have seen the precursors. There are many precursors. But on the other side, lymphoblast give rise to prolymphocyte and prolymphocyte give rise to lymphocyte. So only one precursor is there. So what is the summary? See, I'm writing the summary. So the first cell is hematopoietic stem cell. I guess no one had doubt in this. So the two blasts are formed. Myeloblast, which will give rise to all WBCs except lymphocyte, and lymphoblast that will give rise to lymphocyte. So see how they give rise. So myeloblast convert into promyelocyte, then myelocyte, then metamyelocyte. Promyelocyte, myelocyte, metamyelocyte. Then band form, and the last one is the neutrophil. Give me a thumbs up. In the same way, eosinophil, basophil, and monocyte are also formed. Don't learn their precursors; they are not important. But in the same way, they are also formed. Coming on the lymphocyte, lymphoblast. Lymphoblast give rise to prolymphocyte and directly it give rise to lymphocyte. So only one precursor is there. Everyone give me a thumbs up. Now what I mean, these are the precursors. Once the mature cells are formed, by mature I mean neutrophil on this side and lymphocyte on this side. Mature cells come in the blood. The precursors do not come in the blood. So if you check the bone marrow of a healthy individual, you will get all the precursors in my bone marrow, your bone marrow. But if you check the blood, in the blood you will get only the mature forms. You will not get the premature forms. You will not get the precursors. This is a rule. Give me a thumbs up. Give me a thumbs up. So in the blood, you will get the mature lymphocyte. By mature, I mean it can be neutrophil, eosinophil, basophil, monocyte, lymphocyte. The mature ones. But their precursors, that is myeloblast, promyelocyte, myelocyte, metamyelocyte, band form, they never come in the blood. And from here, lymphoblast, prolymphocyte, they never come in the blood. Precursors never come in the blood. Now, coming on leukemia, the topic directly. What is leukemia? See, the diagram itself depicts. Diagram में ही लिखा है. Itself depicts that when blast come in the blood, it is known as leukemia. Any blast, myeloblast or lymphoblast. So what is leukemia? Leukemia is basically blast in blood. In short, if I say in one line the definition, it is blast in blood. Arrival of, now why the blast will come in the blood, I will tell you. It is due to mutations. So some mutations are taking place inside them. I will tell you the exact mutation, but it is the arrival of blast in the blood. Give me a thumbs up. So it is the myeloblast or lymphoblast, they arrive in the blood. So arrival of the blast in blood. Yes, absolutely right, mad student. It is arrival of the blast in the blood. And blast, once they come in the blood, they are known as tumor cell. So the tumor cells here are the blast. So blasts are coming in the blood and giving rise to leukemia. What is lymphoma? So most of the students even have confusion. What is leukemia? What is lymphoma? They don't even understand the difference between them. So arrival of blast in the blood is leukemia. After coming in the blood, these blasts will enter in various solid organs. They can enter in spleen, they can enter in liver, they can enter in lymph node. So those solid organs will have masses inside them made up of blast. And this is known as lymphoma. So basically, leukemia is a blood cancer and lymphoma is a cancer of solid organs. In leukemia, blasts are present in blood. In lymphoma, the blasts are present in solid organs. So everyone give me a thumbs up if you got the difference between leukemia and lymphoma. So leukemia is a blood cancer due to the abnormality in bone marrow, and lymphoma is the cancer of solid organs. It can be liver, spleen, lymph node, bone marrow, that's it. Give me a thumbs up, right? So you can see the complete story. So when blasts are normal in the bone marrow, this is the bone marrow. When blasts are present in bone marrow, it is an absolutely normal situation. It is in me, you, every healthy individual. We all have blast, but we have blast in our bone marrow. We don't have blast. Healthy individuals don't have blast in blood and tissue. So when blasts leave the bone marrow and they arrive in the blood, it is known as leukemia. And from the blood, when blasts enter the solid organs and form masses in the solid organ, it is known as lymphoma. So in leukemia, blasts are present in the entire blood. You cannot separate them. And in lymphoma, blasts form a specific tissue, a specific nodule. You can do the surgery and separate it. So lymphoma is a solid cancer. Leukemia is a cancer of the blood. So we have understood that. Now the next question, why blasts are coming in the blood? Why these blasts are coming in the blood? So actually, inside the bone marrow, this is hematopoietic stem cell. As I have told you, the father of all cell, hematopoietic stem cell, gave rise to two cells, the myeloblast and lymphoblast. Right? Now let's talk about the three type of cells in the blood. RBC, WBC and platelet. RBC, no further type. Platelet, no further type. But WBC is of 5 type. So 1 RBC, 1 platelet and 5 WBC, total 7 type of cells are formed from here. From hematopoietic stem cell, the 7 type of cells are formed. You got my point? What are the 7 type of cells? So RBCs are formed from myeloblast. All RBCs. WBCs are also, platelets are also formed from the myeloblast. And among the WBC, there are 5 WBC now. The 4 WBCs are formed from myeloblast. That is neutrophil, eosinophil, basophil and monocyte. But the lymphocyte is formed from lymphoblast. So you can see from the 7 cells, 6 of the cells are myeloid origin. The last cell, the 7th one, that is lymphocyte, it is lymphoid in origin. Give me a thumbs up. Now, what is actually happening? There is all cells have nucleus. The nucleus have chromosomes and the chromosomes have genes. Yes or no? So, whenever there is mutation, either in the myeloblast or in the lymphoblast, there is some mutation. The cause of the mutation can be a virus, can be a bacteria, it can be some ionizing radiation, it can be physical, chemical, biological, any cause. So that is causing mutation. Due to mutation, there is uncontrolled mitosis of the blast. So when myeloblast have uncontrolled mitosis, so this myeloblast will proliferate abnormally and it replaces all other cells. It replaces all other cells. So this is known as myeloid leukemia, right? And when and these will come in the blood. This will be spilled in the blood. The word is spilling. They will be spilled in the blood. And when the same mutation takes place in lymphoblast, lymphoblast will do uncontrolled mitosis and they will replace all other cells and they will be spilled in the blood. So basically, 2 type of leukemias are there. When myeloblasts are coming in the blood, it is known as myeloid leukemia. And when lymphoblasts are coming in the blood, it is known as lymphoid leukemia. Everyone give me a thumbs up. These are the basics. So myeloid leukemia, myeloblast will come in the blood. It is spilled in the blood. And in lymphoid leukemia, lymphoblast will come in the blood. It will be spilled in the blood. So 2 type of leukemias are there, right? Now, why I have drawn this diagram to show you in all leukemia, whether myeloid or whether lymphoid. In myeloid leukemia, myeloblast is replacing all other cells because of uncontrolled mitosis. And in lymphoid leukemias, lymphoblast is replacing all other cells because of uncontrolled mitosis. So whatever is the leukemia, patients have anemia because RBCs are less. Patients have thrombocytopenia because platelets are less. And patients have infections also because the mature WBCs are less but the immature one are more. So practically, technically speaking, patients have pancytopenia. So all the leukemia patients have 3 complaints. Number 1, anemia. Due to anemia, patients have weakness, fatigue, lack of energy, lethargy, lack of concentration, right? Patient have thrombocytopenia, that is less platelet. Patient have bleeding problems, right? Epistaxis, other bleeding problems, right? And patients have infection. Now you should have a question, ma'am, WBCs are increasing in leukemia. Still, why you are saying infection? WBC is the defense. But I am saying all the WBCs are more, but they are immature one, not the mature one. So that's why patients have infection. Although WBCs are more, but the immature one are more. The mature one are less. So patients have infection. So 3 symptoms are common, whatever is the leukemia. Anemia, thrombocytopenia, and infection. Give me a thumbs up. Everyone give me a thumbs up. So here in this diagram, you can see, can I define leukemia and lymphoma now? What is leukemia? Leukemia, there is a problem in the bone marrow. There is mutation in the bone marrow. Give me a thumbs up. There is a mutation in bone marrow so that large number of tumor cells, by tumor cells I mean blast, the blasts are coming in the blood, right? And lymphoma is the proliferation of the blast in the tissues, in the solid organs. So leukemia is a neoplasm of the blood cell. It is a blood cancer. And lymphoma is a solid tumor. It involves spleen, liver, other organs, lymph nodes, right? So that is the thing. Now when lymphoblast is coming in the blood, okay, let me show you this diagram again. Can you see here? When myeloblast is coming in the blood, it is known as myeloid leukemia. When lymphoblast is coming in the blood, it is known as lymphoid leukemia. Now both can be acute, can be chronic. Two possibilities are there. Either sudden or gradual. That is acute or chronic. So four type of leukemias are there. This is acute myeloid leukemia. So this one is acute as well as myeloblast is coming. That's why acute myeloid. Chronic myeloid leukemia. So this one is chronic, but still myeloblast is coming in the blood. So chronic myeloid leukemia, AML, CML, both are myeloid. In both of them, myeloblast will come in the blood. Coming on lymphoid leukemias, one is acute, one is chronic. So acute lymphoid leukemia, right, and chronic lymphoid leukemia. Both are lymphoid. In both of them, lymphoblast will come in the blood, but one is acute, one is chronic. Everyone give me a thumbs up. Everyone. So we have four type of leukemias. So leukemias, lymphomas. First understand the difference between them. Leukemia is blast in blood and lymphoma is blast in solid organs or in tissue. So leukemia is a blood cancer, lymphoma is a cancer of solid organ. Both occur due to mutations of the blast in the bone marrow. Leukemia can be lymphoid, can be myeloid. In lymphoid, lymphoblast will come. In myeloid, myeloblast will come. So both can be acute and chronic. So four type of leukemias are there. ALL, CLL, both are acute and chronic forms of lymphoid. AML, CML, both are acute and chronic forms of myeloid. Coming on lymphomas. Lymphomas are of two types, Hodgkin's and non-Hodgkin's. Now, what is this classification based on? So, I will tell you later on when I will start lymphomas. Let me first finish leukemias and concentrate on leukemias. Shall I start leukemias? Everyone give me a thumbs up. Jitne audience, utni thumbs up in the chat box. So, it will indicate that you all are listening my lecture. So, what my student is saying, you have finished your first internals and okay. Thank you. Thank you for the compliment and stay connected. So I will finish the entire syllabus till your finals. Finals, right? Okay. So you can see the classification of the leukemias in front of you. The lymphoid, the myeloid. Shall we continue? Shall we continue? So these are the precursors I have told you. You just revise the precursors before starting leukemia. So the first cell is hematopoietic stem cell. Always, right? So either myeloblast is formed or lymphoblast is formed. यहाँ तक तो सबको पता है. चलो tell me the precursors. Who will tell me precursors here? Myeloblast give rise to promyelocyte, then myelocyte, then metamyelocyte, then band form, and then neutrophil. Please learn the complete series. So it is MB, PM, M, MM, BF, and N. If you say one word. So say the full form. Myeloblast, promyelocyte, myelocyte, metamyelocyte, band form, neutrophil. Right? And say on the other side, lymphoblast. What is the precursor? Only one precursor. Prolymphocyte, which directly give rise to lymphocyte. It's very easy. Prolymphocyte give rise to lymphocyte. So lymphoblast, prolymphocyte, lymphocyte. So see here in the diagram, you can see here. Can you appreciate this cell? This is myeloblast. So it gives rise to promyelocyte. You see this is promyelocyte. This is myeloblast. It gives rise to promyelocyte. It gives rise to myelocyte. It gives rise to metamyelocyte. This gives rise to band form. And this gives rise to neutrophil. So ultimately neutrophil is going in the blood. And these all are present in the bone marrow, not in blood. So ultimately neutrophil is going in the blood, the mature one. Give me a thumbs up. See the second one. This is lymphoblast. Lymphoblast. It gives rise to prolymphocyte, only one precursor. And it directly gives rise to lymphocyte, and lymphocyte will go in the blood. Only the mature one will go in the blood. Shall we continue? So if you know the precursors, you are well prepared to study the four type of leukemias. If you got the basics, that these two are myeloid leukemia, these two are lymphoid. In these two leukemia, in all of them, the blast will come in the blood. That's why they are leukemia. But which blast? In the first two, myeloblast will come in the blood. That's why both of them are myeloid. One is acute, one is chronic. In both of them, lymphoblast will come in the blood. That's why they are lymphoid. One is acute, one is chronic. But ultimately, all are leukemias, that is blast in blood. So that is common in all of them. Blast in blood. Shall we continue? Let me start. Okay, acute, chronic you got. There are two types, acute and chronic. Acute are very rapid in onset, chronic are slow. So acute have poor prognosis. Both acute, myeloid, lymphoid, very poor prognosis. Chronic have relatively good prognosis, right? Okay, so ultimately, which type of leukemia is it? Whether myeloid or lymphoid. The first thing is whether the leukemia is myeloid or whether the leukemia is lymphoid. The second point is acute or chronic. Whether it is acute, chronic, that is the second stage. But first stage, whether it is myeloid or lymphoid depends on what? Depends whether myeloblast is coming or lymphoblast is coming. So in the blood, what is present? Just suppose there is a person, there is a patient. I am suspecting leukemia in this person, but I don't know which leukemia. So what I will do? I will take the blood sample of this person in a test tube and then I will prepare a slide. I will take a slide. I will take one drop here. I will prepare a smear. I will stain it and I will see it under microscope. Now in the microscope, it's the thing that what is present. So it's the cell that will decide. If myeloblast I can see, I will say it is a myeloid leukemia. And if lymphoblast I will see, I will say it is lymphoid leukemia. So it's very important to differentiate between myeloblast and lymphoblast before starting the 4 type of leukemia. So I will teach you all 4 type of leukemias one by one. Before that, see the differences between myeloblast and lymphoblast, without which you cannot understand the 4 type of leukemias. So myeloblast and lymphoblast both are blast. Normally they are present in bone marrow, but once due to mutation they can proliferate, they can do uncontrolled mitosis, and they can be spilled. They can be spilled from the bone marrow to the blood. You can see myeloblast. Now compare the size. Compare the size. Myeloblasts are relatively larger, lymphoblasts are relatively smaller. A little bit differences there. Compare the cytoplasm. In myeloblast, now you can see this is complete nucleus, right? This is nucleus, and the remaining one is the cytoplasm, right? Here, this is the nucleus. I hardly found any cytoplasm. Hardly. A small rim, periphery rim of cytoplasm. So cytoplasm is moderate here, scanty here. तो यहाँ पे सेल छोटा भी है और cytoplasm is scanty है. So lymphoblast is smaller also, and cytoplasm is also very scanty. Right? You see the nucleus of both of them. Here the nucleus is fine chromatin, and here it is coarse chromatin. Okay. See the nucleoli inside the nucleus. I can see 1, 2, 3, 4 multiple nucleoli inside nucleus. Here nucleoli are indistinct. Right. The most important difference is the iron-rod. Iron-rod. What is iron-rod? Iron-rod is a rod, red color rod-shaped structure, which is made up of granules, and it is present in myeloblast cytoplasm. It is never present in lymphoblast. So it is present in myeloblast and it is absent in lymphoblast. सुनो मेरी बात, lymphoblast में तो कभी नहीं होगा. Myeloblast में may be present, may be absent. It is not that all myeloblasts will have iron rod. Some will have, some will not have. Give me a thumbs up. So myeloblast may have, may not have, but lymphoblast will never have. You got my point? You got my point? Myeloblast may have, may not have. हिंदी में कहें तो myeloblast में हो भी सकता है, नहीं भी हो सकता है, लेकिन lymphoblast में कभी नहीं होगा. Lymphoblast will never have. You got my point? And it is a red color rod shaped structure. So can I say myeloblasts are of 2 types? The one in which in the cytoplasm iron rod is present, and the one in which cytoplasm no iron rod is present. So let me draw the iron rod in one of them. Many iron rods are present. The other one, iron rod is, both are myeloblast. So such a myeloblast in which multiple iron rods are present, it is known as Pagod cell. It is known as Pagod cell. Shall I proceed ahead? So what is Pagod cell? Pagod cell is a myeloblast with multiple iron rods. So we have seen the differences between myeloblast and lymphoblast. The same differences are shown here also. You can see this one is myeloblast, this one is lymphoblast. Try to appreciate the iron rod here. Can you see rod-shaped structure? See the size, see the cytoplasm, and see the iron rod. Again, myeloblast, lymphoblast. Try to appreciate the iron rod. Iron rod in the myeloblast, but lymphoblast will never have that. Let's start leukemias. Now it's time to start leukemias. I will first teach you myeloid leukemias, in which myeloblast will come in the blood. So when myeloblast will come, it is automatically myeloid leukemia, right? Now myeloid leukemias are of 2 types, acute and chronic. So acute myeloid leukemia and chronic myeloid leukemia. So AML and CML. So you should ask me a question, ma'am, how to identify whether it is AML or CML? In both of them, in the blood, only myeloblast will be present. So there is a way to differentiate them. Let me start. So there is a way. So I request all my dear students to make this comparative table with me. If you are making this comparative table with me now, you are making the topic super duper easy. So once this topic will be finished and you will fill this table with me, you can revise entire leukemia in just 5 minutes before your exam. So whether you are targeting for your university exam second prof, whether you are targeting for any of the competitive exam, NEET PG, FMG, INICT, next, USMLE, तुमको जो देना है, questions will be from this table only, that I can challenge, that I can guarantee, right? So make this table with me. It will be in a comparative form and easy to remember, right? So in this sequence, I am going to teach you the 4 types of leukemia. First, I will teach you CML. Then I will teach you AML. The myeloid will be completed. Then I will teach you ALL, right? And then CLL. So in myeloid, first I will teach you chronic, then acute. But in lymphoid, first I will teach you acute, then chronic. There is a reason behind that. I want to do a comparison between both acute. So that's why उनको पास में रखना है मुझे, right? So in this sequence, I will teach you all 4 leukemias, right? In each of them, first I will tell you the definition of each of them in the introduction. The most common age of presentation. Looking at the patient's age, that will give you a clue which type of leukemia is it, right? The next is the pathogenesis. So name the mutation which results in uncontrolled mitosis here. So mutation will be different. So mutation will be in myeloblast or lymphoblast, but the name of the mutation, exact chromosome, exact gene. तो वो मैं चारों में बताऊंगी, right? Classification if applicable. So there is no classification here, no classification in the chronic, but both acute have the classification. So I will tell you classification in both WHO classification as well as FAB classification. More important is FAB classification. French, American, British, FAB classification is applicable in both acute, AML, ALL. So acute is of 8 types, myeloid is of 8 type, lymphoid is of 3 type. I will tell you everything, don't worry. Clinical features, so you will compare the clinical features of all. Some clinical features are common, some are different. So looking at the clinical feature in a clinical scenario based question, you can identify looking at the age, clinical features, mutations, lab diagnosis. Now being a doctor, being a good practitioner, good doctor, what investigations you will order? What investigations you will order to confirm your diagnosis if you have suspicion of one particular type of leukemia? Then treatment. So we are covering treatment also. So what treatment you will offer in which of them, right? And then the prognosis, prognostic factors are very important. As soon as you will give the diagnosis to the patient, you are having blood cancer, the family collapse, right? The complete family, the relatives, the patient himself or herself, they will collapse. And they will ask you, doctor, जो भी treatment है, जो भी सब है, the ultimate is prognosis. How is the prognosis? What is the survival time? Is it a cure, yes or no? So that is the bombarding question the patients and the family will ask, and it's very obvious. So you should be able to answer them. So there is a list of prognostic factor in each of them. So you should examine all the prognostic factor. Based on them, you can answer the prognosis of this particular variant is good or not. So that will, mentally the family, the patient will be prepared for the prognosis. So this is the complete leukemia, everything about leukemia, and we are going to cover in a super duper interesting and very easy way. So shall I start? With your permission, shall I start? I'm starting with the first one, CML. So let's start CML. What is the full form of CML? Chronic myeloid leukemia, CML. Shall I start CML? Are you people with me? So write down the introduction. In the introduction, write down the definition of CML. Please fill this table with me. If you have not taken the notebook and pen, it's not late even yet. Take out your notebook, take out your pen and start filling. Please believe me, it is useful for you, right? So start the CML. Write the introduction, write the definition of CML right here. In this definition of the CML, any patient coming to you with these 4 problems, the diagnosis is going to be CML. Now, what are the 4 things which are hallmark features of CML? So, you will see the WBC count is raised. There is leukocytosis. How much? What is the normal WBC count, by the way? What is normal WBC count in a healthy individual? It is 4,000 to 11,000. 4,000 से 11,000. Here the WBC count is more than 50,000. Maybe 50,000 to 1 lakh. Maybe more than 1 lakh also. Maybe up to 2 lakh. So 11,000 की जगह 1 lakh, 2 lakh. So that is leukocytosis, right? But all the WBCs are immature. None of them is mature. All of them are immature. The bombarding of immature. So that is the most important criteria. If you see the WBC count on a CBC, it is in lakhs, right? But if you make a slide, what WBCs are there? लाखों में क्या है? न्यूट्रोफिल है, इओसिनोफिल है, बेसोफिल है, लिम्फोसाइट है, मोनोसाइट है. कौन सा WBC लाखों की तादाद में आ गया है? So in million, in lakhs, which one of the 5 is present? You see none of them is present. All the precursors are present. So that is the most important finding in CML. Number 1, right? Number 2, basophilia. Many of the WBCs will be basophil. So basophilia is prominent here. It is very visible. Normal basophil is less than 1%. Out of the 100 cell, only 1 cell is basophil normally in healthy individual. If you search basophil in your own blood, every 100 WBC you will find only 1. But here you will get many basophils, right? Patient has splenomegaly. You can palpate the spleen of this patient. And if you do the chromosomal analysis, that is cytogenetics, you will find Philadelphia chromosome present in this patient. Based on this 4 criteria, you label the patient, you are having a disease known as CML. It is a blood cancer and you are having CML. You can label that. So now what is the meaning of these 4? Why these 4 findings are present in this patient? That we will understand here after completing the topic. But learn the definition. Learn the definition is having 4 points. You know the 4 points. Number 1, WBC count is increased. That is leukocytosis but with immaturity. Number 2, basophilia. Number 3, splenomegaly. And number 4, Philadelphia chromosome. Give me a thumbs up. Are you people there or not there? You are not responding. Let me see if your chat is updated or not updated. I can't see it's updating. Either you are not responding or it's not updating. Let me confirm. So you're not responding. I guess it is updating. Give me a thumbs up. Come on. Are you people there? So, Nikita, YouTube Shorts, Nitesh, Awesome, Med Student, Suraj. Are you people there? Give me a thumbs up, everyone. So, shall we proceed? After the introduction, come on the age. It is most common in the old age, after 50 years of age. It is very common in old age, after 50 years of age. It is more common after 50 years of age. So, we are done with the introduction. We are done with the age. Now let's come on the pathogenesis. As I have told you, what is the problem? What is the problem here? So let me draw a bone marrow to show you the problem. This is the bone marrow. Inside the bone marrow, this is the first cell, hematopoietic stem cell. From the hematopoietic stem cell, this is myeloblast and this is lymphoblast. Tell me myeloblast wale precursor. I'm not interested currently in lymphoblast. I'm interested in myeloblast. So what is the complete series? So myeloblast give rise to promyelocyte. Promyelocyte give rise to myelocyte. Myelocyte give rise to metamyelocyte. Then band form, and then ultimately neutrophil, eosinophil, basophil, monocyte. So this is the complete series, right? Now mutations are taking place here due to physical, chemical or viral, anything. Mutations are taking place. So let me draw all the precursors. Precursors में mutation हो रहा है. So let me draw these precursors separately. Right. So let me draw a cell. Now which cell is it? Tell me, what is the cell? This can be any precursor cell. This can be myeloblast, myeloid cell. This can be myeloblast. This can be promyelocyte, myelocyte, metamyelocyte or band form. So any of the precursor of neutrophil, eosinophil, basophil, that is the cell. This is the nucleus of the cell. Right. All cells have nucleus. All cells have 46 chromosomes. Yes or no? You agree or don't agree? You agree. So 46 chromosomes means 23 pairs. All cells have 23 pairs of chromosome. This is pair number 1. This is pair number 2. Pair number 3, 4, 5, 6, 7, 8, 9, 10, 11. Likewise, total 23 pairs are there. I am not interested in all pairs. I am interested in pair number 9 and pair number 22. Let's draw on the another page. I will draw the two pairs, pair 9 and pair 22. So just suppose this is pair 9, pair number 9. Please everyone concentrate. And just suppose this is pair number 22, right? Inside the precursor cell's nucleus, the precursor of the neutrophil, the myeloid precursors. So this can be happening inside myeloblast, promyelocyte, myelocyte, metamyelocyte, band form, anything. On chromosome number 9, we all, me, you, everyone have a chromosome ABL. The name of the chromosome is ABL. It is already present in me also. It is present you. Every healthy individual, we have two ABL copies, right? On each on one of the chromosome 9. And on chromosome 22, we have another chromosome. We have another gene. The name of the gene is BCR, right? So we have the name of the gene is ABL. It is present on chromosome 9 in all of us. We all have on chromosome 22 another gene. The name of the gene is BCR. So ABL is present on 9 and BCR is present on 22 in a healthy normal individual. Whenever they are present on their respective chromosome, that is 9 and 22, they are performing their function normally and the cell is doing the mitosis normally. Normal mitosis is there. This is all inside the cell. So the cell is doing normal mitosis. It is normal till now. But imagine this is happening inside the cell. Let me draw the cell. This is the nucleus of the cell, right? Now, due to some mutation, physical, chemical or viral, the three type of mutation, right? Any of the mutation, there is mutation taking place. Now, there are various type of mutation, point mutation, deletion, addition, So here translocation will take place. What do you mean by translocation? In translocation, one portion of one chromosome is given to another and in exchange of it, some other part of another chromosome given to the first. So basically, they will do the exchange, right? Two neighbors, they exchange vegetables, na? एक के घर सब्जी बनी तो दूसरे को दिया, दूसरे ने उसको दिया. Exchange happens. So in the same way, these two will exchange their genes. They will exchange their genes. So what will happen during this exchange? Please understand. ABL on chromosome 9, that will go to 22. So ABL will be shifted to 22. So on 22, this ABL is going. It is going on 22. So ABL will go to the 22, but on 22, BCR is already present. So due to the fusion of the two gene, a third hybrid gene is formed. That is known as ABL-BCR fusion or hybrid gene. And that gene is abnormal, that is deadly. That will cause uncontrolled mitosis of this cell. You got my point? So ABL from chromosome 9 is going to 22 on which BCR is already present. So it is going just near BCR and fusing with BCR. So due to the fusion or hybrid, a new gene is formed. Give me a thumbs up. Now you will say, you will ask me, ma'am, in exchange, what 22 is giving to 9? 22 is giving an empty portion to 9 that doesn't contain any important gene. So exchange is over. So one portion of this chromosome going to here to there and another portion of another chromosome coming from. But this exchange may 9 is giving an important gene to 22. That is ABL. And 22 already have BCR. Due to this ABL-BCR, fusion gene is formed. And that lead to uncontrolled mitosis of this cell. So this cell will do uncontrolled mitosis. It will proliferate from 1 to 2, 2 to 4, 4 to 8, 8 to 16, 16 to 32, likewise. So bone marrow will be filled with these cells and after saturating the bone marrow, they will be spilled in the blood. Once all these cells coming in the blood, it's leukemia. Give me a thumbs up. You got my point? You got my point. Now look at the chromosome 22. At chromosome 22, fusion is happening. Chromosome 22 पे fusion हो रहा है. Fusion is not happening at 9. That's why in this, chromosome 22 is known as Philadelphia chromosome. Who is Philadelphia chromosome? Philadelphia chromosome is chromosome 22. It is the name given to this chromosome specifically because fusion gene is formed on this chromosome. Everyone give me a thumbs up. Yes, Nareshwar, you are absolutely right. The fusion gene. You should ask me, ma'am, why this fusion gene is causing uncontrolled mitosis? Why? Fusion gene is ABL-BCR. Because of the fusion gene, all gene expressed with the help of enzymes, with the help of protein formation. So gene do transcription and translation. And with the help of transcription and translation, gene form protein. And they express with the help of protein. So this fusion gene should also express with the help of protein formation. So this fusion gene, the abnormal ABL-BCR fusion gene, it will do transcription, it will do translation, and it will form a protein which is an enzyme. The name of the enzyme is tyrosine kinase, and it is an abnormal enzyme that is leading to uncontrolled mitosis. Excellent, Nareshwar, absolutely right. Give me a thumbs up if you all got it. Right, right. Yes, it is 210 kilodalton. I will tell you exact kilodalton when I will teach you ALL. Because in ALL also 922 mutation will take place. Just a second. So there also 922 mutation take place. But the kilodalton, the fusion gene ka size will be different. So I will tell you exact size there when I will teach you ALL. Wait a while. So everyone give me a thumbs up if you got the pathogenesis. So let me show you the pathogenesis. So pathogenesis is basically a translocation, an exchange taking place between 9 and 22. Now it is universal how to write translocation. Write the number of the two chromosomes and in between give a semicolon. It is not a comma, it is a semicomma. You know a dot, a comma, it is semicolon. And give small brackets. Don't give big brackets. And after that write small t. It is universal, write this only. So it means translocation is taking place between 9 and 22. If you want to write the name of the gene, on 9 the name of the gene is ABL and on 22 the name of the gene is BCR. So it is also known as ABL-BCR translocation. ABL is going towards BCR. BCR is not coming towards ABL. And the chromosome number 22 is known as Philadelphia chromosome on which this fusion is formed. And this is happening where? किसके अंदर हो रहा है? All these cells, the precursor cells of the neutrophil. So it is happening inside myeloblast, promyelocyte, myelocyte, metamyelocyte and band form. Inside all of them Philadelphia chromosome is formed. That's why these all are doing uncontrolled mitosis. So they will fill the complete bone marrow and they will be spilled in the blood. So give me a thumbs up. So same diagram you can be seen. You can see the same diagram. You can understand the same diagram here. You can see normal. This side is normal and this side is CML. So see first normal. On the normal, you can see the 2 chromosome 9 and you can see the 2 chromosome 22. On chromosome 9, appreciate ABL. If you can zoom, you can see a small ABL. On 22, you can appreciate BCR. The yellow one is the BCR. So they are present separate and they are doing their job. The cell is normal. Normal mitosis, no problem. But during exchange, can you see this is going? See the arrow where it is going. ABL from 9 is shifted to 22. So on 22, see the two colors, yellow, blue, both are there. So they are fusing. ABL and BCR are fusing and a fusion gene is formed. Right. In exchange of it, the 22 is giving an empty portion. Can you see this pink portion? Empty portion which doesn't contain any important gene. So 9 को कुछ problem नहीं है, but on 22 fusion gene is formed that leads to formation of abnormal tyrosine kinase and that leads to uncontrolled mitosis. So this cell proliferate, right? So ABL BCR hybrid gene is formed. That is the problem. So normally ABL is present on 9, BCR is present on 22, and they are forming normal tyrosine kinase. No problem. The mutation, the mitosis is normal. But during translocation, during mutation, translocation is one of the type of mutation. Exchange take place. So basically, ABL from chromosome 9, it is leaving chromosome 9 and moving towards 22. After moving towards 22, ABL BCR hybrid gene is formed on 22. And that's why chromosome 22 is known as Philadelphia chromosome. This hybrid will form an abnormal tyrosine kinase that have abnormal signal transduction that will lead to uncontrolled mitosis of the cell and that leads to CML. I want thumbs up from everyone, appreciation from everyone. You got the pathogenesis. So can I say ABL BCR gene is the hallmark of CML without which we cannot label the patient as CML? So ABL BCR gene means Philadelphia chromosome. So can I say Philadelphia chromosome is the hallmark of CML? Yes. Philadelphia chromosome or ABL BCR fusion और 922 translocation सबका मतलब एक ही है. The meaning of all is same. So either you say 922 translocation, either you say ABL BCR gene, or you say Philadelphia chromosome. All means that the mutation is same and an abnormal protein is formed. That is the pathogenesis of CML. Give me a thumbs up. So till now what we have learned, we are studying the first leukemia. We have to go for. This is the first one, CML. We have seen the introduction or definition of CML. We have seen the age, at what age it is common, and we have seen the pathogenesis. The pathogenesis of CML. In the introduction, I taught you there are 4 findings without which we cannot label a patient as CML. You know that. Age is more than 50 years. It occurs more than 50 years of age in patients. That is an old age. Pathogenesis is 922 translocation. Either say 922 translocation or say ABL-BCR translocation fusion or say Philadelphia chromosome. सबका मतलब एक ही है. So after pathogenesis, I am coming on the phases of CML. So CML don't have any classification. CML is only CML. But inside the CML, there can be 3 phases. Now it depends. Patient is coming to you at what phase. All the phases can occur in a single patient also. From time to time, the phase can vary. So there is chronic phase, accelerated phase, and blast phase. Right? CAB. You can learn like that. CAB. Chronic accelerated blast. So what does it depend on? It depends how many blasts are coming. What is the pathogenesis? Once again, tell me. Once again, you tell me what is the pathogenesis to understand the phases. So this is the bone marrow. Inside the bone marrow, the first cell is hematopoietic stem cell. अब तो सबको रट गया होगा. The two blasts are myeloblast and lymphoblast. Myeloblast से क्या क्या बनता है? चलो बताओ. Myeloblast give rise to promyelocyte, myelocyte, metamyelocyte, band form, and neutrophil. In the same way, eosinophil, basophil, monocyte. So that is all myeloid series, right? And I am saying that what I am saying. I am saying that the mutation is taking place here. The 922 mutation, that is translocation ABL-BCR fusion gene is formed inside all the precursors. So all these precursors, normally these precursors don't come in the blood. So let me draw a blood vessel here. So this is the blood vessel. This is a blood vessel. So inside the blood vessel, normally, I'm talking normally mature neutrophil, eosinophil, basophil and monocyte, they come. Normally, the precursors do not come. But now, since the mutation is taking place in all of them, so all of these precursors are doing uncontrolled mitosis. So they will fill the bone marrow. After filling the bone marrow, they will be spilled. The word said is spilled. They will be spilled in the blood. Spillage of the precursors from the marrow to the blood is CML. So all the precursors will come here. So basically, myeloblast will also come, promyelocyte will also come, myelocyte will also come, metamyelocyte will also come, band form will also come. Apart from which some mature form, neutrophil, eosinophil, basophil and monocyte. ये सब थोड़े थोड़े होंगे, but precursors will be many. Give me a thumbs up. So blood is full with the precursors. Give me a thumbs up. Now in the blood, I am taking a blood sample in a test tube. So I have to decide the phase. The patient is in which phase. So that depends on the blast. I will see the percentage of the blast out of the total cell. So I am not interested in promyelocyte, myelocyte, metamyelocyte, band form. Either I am interested in blast or I am interested in basophil. Based on which I will decide the phase. You got my point? So there are 3 phases. As I have told you, chronic, accelerated and blast. Now see the blast, myeloblast ka percentage. If the myeloblasts are less than 10%, it is chronic phase. If it is 10 to 20%, it is accelerated phase. And if it is more than 20%, it is blast phase. Give me a thumbs up, right? So less than 10%, 10 to 20%, more than 20%. So based on the percentage of myeloblast, we decide the phase, right? Apart from it, the second criteria will be the basophils. Give me a thumbs up. That is the 3 phases. So we have done the introduction. You know the definition of CML. Any patient coming to my clinic whose age is more than 50 years and who is having 4 problems. Number 1, in the CBC, I found leukocytosis. The WBC count is in lakhs. Normal WBC count in a healthy individual is 4,000 to 11,000. Instead of 11,000, it is 1 lakh, 2 lakh, right? Like that. So, and if I make a peripheral smear, most of them are immature, right? So that is the first criteria. Second, the patient have many basophils in the blood. The third, patient has splenomegaly, right? And the fourth, this patient has splenomegaly, and fourth, if you do the cytogenetics, you will find Philadelphia. These 4 criteria fitting, the patient is labeled as CML. Age should be more than 50 years. Pathogenesis we have already seen. It is 922 translocation, Philadelphia chromosome. There is no classification, but we have seen the phases. We have seen 3 phases, CAB, chronic accelerated blast, based on the percentage of the blast. Now, it's time to study the clinical features. Patient will come to you saying, doctor, I am having this complaint. Patient will not come to you, doctor, I am having CML, treat me. No, it's your job to make the diagnosis. Patient will give you clinical features, that is symptoms and signs. So tell me the symptoms and signs of CML. Not only CML, any leukemia. I have taught you all already. So this is the bone marrow. Inside the bone marrow, this is the first cell, hematopoietic stem cell. So this is myeloblast and this is lymphoblast. There are 3 blood cells, RBC, WBC and platelet. RBC have no further type, platelet have no further type, but WBC are of 5 type. So from where they are formed? All RBCs are formed from myeloblast. All platelets are also formed from myeloblast. Among the WBC, all WBC, that is neutrophil, eosinophil, basophil and monocyte. So 4 WBC except lymphocyte, they are formed from myeloblast. So lymphoblast only form one of the WBC, right? Now there is mutation in the precursors of this series. I mean, यहाँ पे अलग precursors हैं, यहाँ पे अलग precursors हैं, यहाँ पे अलग precursors हैं. So mutation currently is taking place precursors here, right? So all these precursors, that is promyelocyte, myelocyte, metamyelocyte, and band form. You know the names of the precursors. They are doing uncontrolled mitosis. That's why they are replacing all others. So patient have less RBC. The first symptom is the anemia. Patient will come to you saying, Doctor, I am feeling very weakness since last few months. I can't work, I can't concentrate, I am lethargic, I am fatigued, and I feel always sleepy. I can't work. So that is the first complaint. Do a CBC, hemoglobin is less. It is 8, 7, 6, maybe, right? So patient is severe anemic. Number one, the reason is this, right? Number two, patient will come to you, Doctor, I am having bleeding from the nose, I am having bleeding from the ear, I am having mucosal bleeding, I am having conjunctival bleeding, so bleeding at multiple sites, and sometimes internal bleeding is also there. And in females, it can be menorrhagia, right? So bleeding problems. If you do a CBC, the platelet count is less. What is the normal platelet count? It is 1.5 to 4 lakh. So platelet will be less than 1.5 lakh. So it is known as thrombocytopenia. So patient will come to you with weakness, fatigue, lethargy due to anemia. Patient will come to you with bleeding, epistaxis, purpuras, and all the bleeding. That is thrombocytopenia. Now, patient will come to you with infection. Doctor, I'm having fungal infection in the mouth. I'm having high grade fever. I'm having cough. I'm having pneumonia. So if you do the X-ray, you will find pneumonia. So all these are infections. Why infections occur? When immunity is less. Who provides immunity? WBC provides immunity. So on one hand, now listen, there is a discrepancy. On one hand, I'm saying RBC is less. Okay, no problem. I'm saying platelet is less. No problem. But I'm saying WBC count is more. I'm saying instead of 11,000, the WBC is 1 lakh, 2 lakh. It is in lakhs, right? It is in lakhs. But on the other hand, I'm saying the immunity of the patient is dropping. Immunity drop. That's why patient is more vulnerable for the infection. Why? The two things are contradictory. On one hand, I'm saying WBC are more. On other hand, I'm saying patient is more vulnerable to infection. Immunity is dropped. Why? Both things are right. I'm saying that, yeah, the WBC count increased, but all of them are immature, not the mature. They are immature one. So most of the WBC which are in 1 lakh, 2 lakh, they are promyelocyte, myelocyte, metamyelocyte, and band form. They are not mature lymphocyte. They are not mature lymphocyte. So mature WBC count decreases. That's why patient immunity drops and patient is more prone to infection. So most three common symptoms of the patient are in front of you. Anemia due to decreased RBC, bleeding problem due to decreased platelet, and infections. I agree WBC increase, but these are premature one. You can say mature WBC decrease. So you can say technically patients have pancytopenia. Technical. We cannot label pancytopenia. Pancytopenia where all three should fall. Here RBC are falling, platelet are falling, but WBC are not falling. They are rising. Instead, patients have infection because the rising one are the immature one. I guess I'm crystal clear in concept, but you people are not interacting. At least respond. Give me a thumbs up in the chat box so that I can understand that you are getting what I mean. Otherwise, I will repeat it. Give me a thumbs up. Come on, everyone. Those who are watching me live, please give me a thumbs up on your gadgets. Right? You are people there? So listen, you are not sleeping. You are awakened. Right? Okay. So that is the first three symptom patient will come to you. Now, all these three symptoms are due to bone marrow failure. So in the bone marrow, only the precursors are proliferating. Rest cells are not proliferating. That is bone marrow failure. You got my point, right? The second, now when such a mitosis is taking place at such a high rate inside the bone marrow, all the precursors are doing division. So there is hypermetabolism in the body. So all the energy of that person having CML will be utilized in the mitosis. So patient will have weight loss, drastic weight loss in the last few months. So patient will come to you saying, Doctor, all my clots become loose. I lost nearly 4 or 5 kg in the last 3-4 months, in the last 2-3 months. So weight loss will be a campaign. Lassitude will be a campaign. Anorexia and night sweats due to hypermetabolism. So these can be the features due to hypermetabolism. These patients also have splenomegaly. Sometimes it's massive. Sometimes it's massive. Because all the cells which are forming, they are destroyed in the spleen. The spleen trying to destroy to compensate. So spleen is seeing that all these cells are abnormal and spleen is trying to destroy them. So hypersplenomegaly can be there. So there are symptoms due to bone marrow failure, that is anemia, bleeding, and infection. You know the reason. There are symptoms due to hypermetabolism, that is weight loss, anorexia, night sweat. Night sweats are typical, right? And there is splenomegaly. So these are the features. So what are the clinical features? Can you summarize the clinical features in a patient with CML? So patient will come to me, to a doctor, with following clinical features. The first clinical features is due to bone marrow failure. Patient is having failure of bone marrow. The second is due to hypermetabolism. and the third is splenomegaly, right? Bone marrow failure patient have anemia features, that is, patient will not say I'm having anemia. Patient will have features of anemia, that is lethargy, weakness, fatigue, lack of concentration, lack of energy. Patient will have features of thrombocytopenia, right? That is, patient have bleeding from various sides, nose, ear, conjunctiva, mucosal bleeding, skin bleeding, purpura, anything, internal bleedings, menorrhagia. So, and patients will have multiple infection. That can be pneumonia, that can be any infection in human body. That can be high grade fever with chills, right? Some infection is there. So that is the bone marrow failure symptoms. Hypermetabolism, it will be weight loss, night sweat, and anorexia, splenomegaly. So these are the clinical features. So when a 50-year-old male having, or not male, any person having these features, suspect CML, first order CBC. First order CBC. In CBC, you will find hemoglobin is less, RBC count is less. Of course, hemoglobin and RBC count will be less. You will find platelet is less, right? And you will find WBC is drastically increased. It is in lakhs. So yes, it is a probable case of CML, but it is not confirmed. Still, it is not confirmed. Why it is not confirmed? There are some infections that can cause increased WBC count. That is known as leukemoid reaction. You have to differentiate CML from leukemoid reaction, right? So before treating the patient, you want to double shot. So double shot is done by cytogenetics, right? Now let's start lab finding. Let's start. These were the clinical symptoms. Now let's start lab finding. In the lab finding, I will be ordering 5 things. So I will ask the patient that I'm suspecting one of the blood cancer in you based on your symptoms and based on your CBC report. I'm afraid that you may have one of the blood cancer. There are 4 types of blood cancer. Patients don't know it's a 4 type. They think that blood cancer is deadly. All blood cancer are deadly. It is not the case. The chronic one are the good. They are not very, they are not very dangerous. The prognosis is relatively good. The acute one are deadly, right? So you have to tell it is one of them, not very bad, but yeah, let me confirm. So for confirmation, we require all these investigation. So we will do a blood picture. We will take a blood sample, we will do CBC in that, and we will make a peripheral smear also and look in the microscope. So that is the blood examination. We will do a bone marrow examination also. We will take the bone marrow, aspirate and biopsy and make a slide and make a smear of that, right? We will do cytogenetics also. Cytogenetics में exact mutation दिख जाएगा. That is the most confirmatory test. Most, but it is very costly, right? In cytogenetics, what does we do? We take the blood out. From the blood, we will take one of the precursor, one of the WBC. Or from that, we will take the nucleus out. From that, we will take the DNA out. So DNA extraction is done, right? It is all at microscopic level, right? So there is a master room. Have you seen cytogenetics lab? They are very unique, right? So cytogenetics lab are not available everywhere. They are very costly labs, costly setup, very expertise is required. So actually inside a cell, inside a nucleus, you are extracting the DNA, and from DNA you are going at chromosomal level, and from chromosomal level you are going to exact gene. So देखो कितना बारीकी से जाके तुम्हें एग्जामिनेशन करना है, and that will be the most specific. तुम्हें दिख जाएगा mutation, so you can find the exact mutation in cytogenetics. You will do cytochemistry. Cytochemistry actually are stains. Cytochemistry मतलब cyto मतलब cell के अंदर हम chemistry लगा रहे हैं. Chemistry मतलब stains. Some special stains are there which are not very important, not very specific, and other investigations. Okay, so let's start with blood picture. In the blood, what you will find, of course, hemoglobin will be less, normocytic, normochromic anemia, thrombocytopenia, platelet will be less. So RBC less, hemoglobin less, platelet less. Let's come on WBC. What is the WBC count? Nearly 2 lakh. What is the normal WBC count? 4,000 to 11,000. In this patient, it will be eye-catching. As soon as you see the CBC report, एकदम से दिमाग पे लगेगा 2 lakh, oh my god, maybe CML, right? So probably, most probably, he is going to convert into CML, but we have to confirm. We have to double shot, right? But if you make a peripheral smear, most of them are immature. By immature, I mean promyelocyte, myelocyte, metamyelocyte, and band form. Yes or no? You will find basophilia and eosinophilia also. These are also the features, right? And you have to see the exact phase, either chronic accelerated or blastic phase, based on the percentage of the blast, right? So see the pictures. Everyone see the picture. Can you see the picture? In this picture, what all cells are there? This is the blood picture. What all cells you can see? I can see this is a neutrophil. This is multilobated. This is a neutrophil. This is a neutrophil. I guess this is a neutrophil. This is a neutrophil. These are the neutrophils. Apart from it, this is a basophil. Can you see? This one is basophil with black granules. This is a basophil, right? Apart from which, I can see this is a eosinophil, red granules. So I am finding neutrophil also, eosinophil also, basophil also. Apart from which, जितने भी cell हैं, these are precursors. Now I cannot identify which of them are promyelocyte, which of them are myelocyte, which of them are metamyelocyte. At your age, I am not expecting you should identify. But yeah, there is a mixture of cell. So promyelocyte is also there, myelocyte is also there, metamyelocyte, and band form are easy to identify. Band form are C-shaped nucleus. The nucleus is C-shaped. So this is band, right? Maybe this is band, right? So multiple cells are there. This appearance is known as garden party appearance. Garden party. So there's a party going on in a garden. So everyone is in different dress. So everyone is dressed differently. Someone is in t-shirt, someone is in shirt, someone is in full suit, someone is in a sari, right? So it is garden party appearance, different type of cells, right? It is not uniform. So this is a typical appearance of CML. See the blood. You can see all type of cells. Any image can come in your exam. You can see this is a eosinophil. You can see this is a basophil. You can see this is the band form, the C-shaped. Multiple cells are there. The same, right? Here also you can see a mixture of cells. So in the blood picture, we will find all cells. We will find myeloblast also, but apart from myeloblast, we will find promyelocyte, myelocyte, metamyelocyte, band form, neutrophil, eosinophil, basophil. Basically, garden party. Learn the word garden party appearance. Everyone give me a thumbs up, come on. Garden party, right? Coming on bone marrow picture. Bone marrow karo, double confirm. How you will do the bone marrow? Take the bone marrow out and do the aspiration. See the cellularity. The bone marrow is full of cell, hypercellular than normal because of hypermitosis, uncontrolled mitosis taking place inside the bone marrow. And all of them are myeloid cell, right? So if you see the myeloid erythroid ratio, it is increased because there is more myeloid as compared to erythroid. So it is everything is myeloid. Erythropoiesis reduced, megakaryocytes reduced. So these are the RBC precursor and platelet precursor. Everyone will be reduced. So blood picture is we are done. In the blood picture, you will get garden party appearance. In the bone marrow, you will get only myeloid precursors. Only myeloid precursors, nothing else. In the cytogenetics, you will find Philadelphia chromosome. You already know what is Philadelphia chromosome. So in the cytogenetics, you will find the exact mutation, and that is the diagnostic test, but very costly. Very costly, but this one is diagnostic. If the patient can afford, they should always do that. And Philadelphia chromosome is the hallmark of this, right? So it is the reciprocal balance translocation. That is the complete name we are giving because exact same length of chromosome is transmitted from here to there. So that is known as reciprocal translocation. Reciprocal exchange is taking place between 9 and 22. That is a balanced translocation between 9 and 22. ABL BCR translocation, Philadelphia chromosome. That is cytogenetics. So blood picture we are done. Bone marrow picture we are done. Cytogenetics we are done. Let's come on cytochemistry. Let's come on. Hello everyone. Am I live? Am I live again? Can you see me? Can you hear me? Give me a minute to confirm if I'm live again. There was some technical error. I guess yes, it's working now. So I'm really sorry. I was unable to connect as there was power cut off and I was not connected with the Wi-Fi and some technical errors have happened and I was unable to connect, go live. So currently, I guess everyone can see me. Give me a thumbs up. Bhola, Madhu, Sufi. Is anyone here? Can you see me live? Can you hear me? I guess I should continue. So I was teaching you CML. I was in the middle of the blood investigations of CML. We have already discussed the blood picture. We have already discussed the bone marrow picture. We have already discussed the cytogenetics. And currently, I am teaching you the cytochemistry. So let's come on the cytochemistry. As I have told you, what is cytochemistry? Cytochemistry are the stains which are used to stain the cells and see what is the finding. So in cytochemistry, the best stain we use to diagnose CML is NAP. Either you say NAP or you say LAP. So what is NAP or LAP? It is neutrophil alkaline phosphatase. That is the name of the stain. Or leukocyte alkaline phosphatase. Neutrophil is one of the leukocyte. Now learn like that. Leukocyte means all WBC. Leukocyte means all WBC and neutrophil is one of the WBC. So leukocyte alkaline phosphatase or neutrophil alkaline phosphatase, that is the stain we are using. So what is the thing here? How should I explain you? So what is the problem in CML? As I've told you, in CML, inside the bone marrow, the first cell is always hematopoietic stem cell. We all know that. From hematopoietic stem cell, either myeloblast or lymphoblast are formed. Myeloblast give rise to promyelocyte, myelocyte, metamyelocyte, band form and neutrophil, right? And lymphocyte में से ये बनेगा. Right. So what is the problem in CML? The problem in the CML is that all the precursors have some mutations. We know the exact mutation. The exact mutation is 922 translocation. That is ABL BCR translocation. That leads to Philadelphia chromosome formation. And because of which all these precursors have uncontrolled mitosis. So because of uncontrolled mitosis, all these precursors are coming in the blood. So neutrophils formed from these precursors are also coming in the blood, right? Now let me withdraw the blood in a test tube. Let me take the blood of this person in a test tube and make a slide out of it. So if I make a slide out of it, here is the slide. In the slide, I can see all the immature myeloid cells. That is pre-myelocyte, myelocyte, metamyelocyte, band form. Now inside a normal neutrophil. Let me draw a normal neutrophil. This is a normal neutrophil. In the normal neutrophil, there is multilobated nucleus. We all know the nucleus is multilobated. In the cytoplasm of a normal neutrophil, there is an enzyme. The name of the enzyme is neutrophil alkaline phosphatase. Neutrophil alkaline phosphatase, NAP, or you can say leukocyte alkaline phosphatase, one and the same thing. It is the name of an enzyme which is present in normal neutrophil I am talking about. But when I talk about the precursors, that is promyelocyte, myelocyte, metamyelocyte, band form, in all of them, the NAP concentration is less. So apply NAP stain. You see high score is there or low score is there. If high score is there, it is normal. If low score is there, it is CML. You got my point? That is the scoring. That is known as NAP or LAP scoring. NAP or LAP score is the score, right? You got my point. So that is cytochemistry. In other investigations, you can see the uric acid level. As I've told you, there is hypermetabolism. There is tremendous mitosis going on. Due to this tremendous mitosis, abundant of cells are formed. All the cells which are formed, they are destroyed also. When a cell destroyed, uric acid will come in the blood and patient will have hyperuricemia. Let me summarize blood investigation. I am teaching you CML, chronic myeloid leukemia. So I'm teaching you CML. Let me summarize the investigation. So let me start with the blood investigation. In the blood investigation, you will find RBCs are less and hemoglobin is also less. One and the same thing. Platelet is also less. That is thrombocytopenia. But WBCs are markedly increased. They are in lakhs. And all the WBCs are premature. You find a garden party appearance. In the garden party appearance, you will get myeloblast, promyelocyte, myelocyte, metamyelocyte, band form, neutrophil, eosinophil, basophil, monocyte. So this appearance is garden party appearance, and based on myeloblast, we divide the phase, whether it is chronic, accelerated or blast. We know that. So this is the blood picture. Coming on the bone marrow picture. In the bone marrow, we find there is hypercellularity. The cellularity is drastically increased. So there is hypercellularity. The cellularity is drastically increased and all the cells are myeloid cells because myeloid hyperplasia is there and Ame ratio is increased. That's why. In the cytogenetics, we find Philadelphia chromosome. You all know what is Philadelphia chromosome. In the cytochemistry, we do a special stain. The name of that stain is LAP or NAP. That is the enzyme present in the cytoplasm. Leukocyte alkaline phosphatase or neutrophil alkaline phosphatase, and the score decreases in CML. The enzyme in the cytoplasm decreases in the CML. Other investigation, hyperuricemia. Everyone give me a thumbs up. Everyone. So these are the investigations, the lab diagnosis. So we are studying CML. Let me complete treatment and prognosis also. Then we will revise the complete thing. So coming on the treatment. What's the treatment? If the patient have anemia, give blood. Give blood transfusion. If the patient have bleeding, give platelet transfusion. So that is supportive treatment. Supportive. Main treatment is a targeted drug. You know the name of the targeted drug. The name of the targeted drug is imatinib. It is a very important MCQ. It is a targeted therapy. Imatinib. The most important therapy in CML. What does it do? What is the problem in CML? Why CML happens? We studied it. It happens due to the formation of fusion gene. ABL-BCR fusion gene is formed. Imatinib inhibits this gene. So imatinib is a drug that is inhibiting the signal transduction of ABL-BCR fusion gene. So no abnormal tyrosine kinase will be formed. So the CML will not present. Because CML में uncontrolled mitosis is happening because of abnormal tyrosine kinase which is formed due to this fusion gene. If this fusion gene is inhibited by imatinib, it will not present. Abnormal tyrosine kinase will not form and the cell will not do uncontrolled mitosis. So CML will not happen. So imatinib is the targeted therapy without any side effects. Imatinib. It comes in the form of the tablet and patient have to take one tablet daily. The only thing, it is very costly. It is very costly, so expenditure increases. But the remission rate is nearly 97%. 97% of the cases, it is the after 18 months of the therapy, there is remission. So imatinib is the drug. Please learn it. Before imatinib, bone marrow transplant was the only cure. So for the bone marrow transplant, there should be a donor. There should be an actually matched donor. But still, the rejections are very common. And before that, some other chemotherapies we also try. Interferon alpha, some chemotherapy, busulfan, cyclophosphamide. But nowadays, we don't give these. we have imatinib. The best drug is imatinib. What are the prognostic markers of CML? There are two different index we use, Sokal index and Hayesford system. In Sokal index, there are 5 criteria we see to see the prognosis of CML. What is the platelet count? What is the age of the patient? What is the spleen size, whether splenomegaly present or absent? What is the percentage of blast? And what is the cytogenetic changes? Means cytogenetics means the fusion gene present or not present. So based on these 5 criteria, we say the prognosis is good or poor. If platelet count are very less, if age is more than 50, spleen size is more, splenomegaly, blast percentage are more, and cytogenetics Philadelphia is present, prognosis is poor. And opposite of it is good, right? Hasford system says that different criteria. Age is common in both of them, right? Blast is common in both of them. Platelet and spleen size is common. But instead of cytogenetics, it uses basophils and eosinophils percentage. So two different systems are there. You should be knowing the criteria for MCQs. So I am done with CML. Out of the 4 leukemias, we have completed the first one. That is chronic myeloid leukemia, CML. Give me a thumbs up. Are you there? Bhola, Madhu, Yamkhabiam. Please give me a thumbs up, right? So that is CML, chronic myeloid leukemia. Can we revise it? Can you help me in revision? What is the definition of CML? Any patient coming to you with increased WBC count and immature WBCs. Any patient coming to you with basophilia. Any patient coming to you with splenomegaly. And any patient coming to you with Philadelphia chromosome, the diagnosis is confirmed. Age is more than 50 years. Pathogenesis में the name of gene which is mutated is ABL-BCR translocation. That is 922 ABL-BCR translocation. There is no classification but 3 phases. Chronic, accelerated and blast. You know the percentage of myeloblast. Clinical features you already know. Anemia due to less RBC. Thrombocytopenia due to less platelet, bleeding disorders and infections due to immature WBCs. Right? Lab diagnosis, we do blood picture, bone marrow picture, cytogenetics, cytochemistry, others. You know that. Treatment, the main drug is imatinib. Imatinib. Apart from it, bone marrow transplant, some chemotherapy and supportive treatment is there. For prognosis, we are having 2 index, the Sokal index and Hayesford index. Shall we move to the next leukemia? Starting the next leukemia is AML, acute myeloid leukemia. Before that, I am having few questions for you. You have to read the question and tell me the correct answer. All the questions are from previous year question papers. So can you see the question? This is the first question in front of you. Can you see the question? On a peripheral smear, there is increased neutrophil, increased basophil, increased eosinophil and platelets. Right? Now, it is highly suggestive of which leukemia? Is it AML? Is it ALL? Is it CML? Or is it myelodysplastic syndrome? So you can see multiple cells are increased only in one leukemia. The correct answer here will be, of course, CML. Right? Okay. This is the next question. Okay, not this one. Yeah. ABL-BCR hybrid gene is present. It's a very easy question. I guess everyone will be right. So ABL-BCR hybrid gene is present where? Is it present in Burkitt lymphoma, retinoblastoma, breast carcinoma or CML? So everyone knows that ABL-BCR mutation, that is the CML, that is 922 translocation. Absolutely right, Nagasri. Absolutely right. The correct answer here is the correct answer D in this case, right? So coming to the next question, shall I read the question? Shall I read the question for you? Okay. A 60, now take the clues from the question. A 60-year-old man. So age is important, it is 60, right? Presents with fatigue and weight loss. Fatigue indicates anemia. Weight loss indicates hypermetabolism, right? Since last 6 months, these are the complaints. Hemogram shows hemoglobin is 10. 10 hemoglobin, 10 gram for a male, he is anemic, right? That's why he's having fatigue. But total leukocyte count is 5 lakh. Oh my God, 5 lakh. The total WBC count is 5 lakh. Out of 5 lakh, 55% are neutrophils, right? 4% are lymphocyte, 2% are monocyte, 6% are basophil, 10% are metamyelocyte. Metamyelocyte are coming in the blood. 18% are myelocyte and 2% are promyelocyte and 2% are blast. So tell me the abnormality. First make the diagnosis. So it is a garden party appearance. All the cells are coming. Myeloblast, promyelocyte, myelocyte, metamyelocyte, bandform, neutrophil, eosinophil, basophil, all the cells. Garden party appearance. So the diagnosis is CML and the correct answer is 922 translocation. Shall I move ahead? So that is the correct answer, right? So we are done with CML. I'm starting with AML now, right? Acute myeloid leukemia. The next leukemia, AML, acute myeloid leukemia. Shall I start? Shall I start? Shall we move ahead? Acute myeloid leukemia. So I'm starting the next myeloid leukemia, acute myeloid leukemia. Now what is the difference here? From CML, how does AML differ? AML differed from CML by two ways. I would like to draw a beautiful diagram for you to explain you the difference between CML and AML. Again, this is the bone marrow, this is the blood vessel, and these are the solid organs, maybe liver, spleen, lymph node, multiple solid organs. You can see this is bone marrow, you can see this is blood vessel, and you can see this is solid organs, right or wrong? You can see the three things, right? In the bone marrow, you can see this is the hematopoietic stem cell from which either myeloblast or lymphoblasts are formed. I'm interested in myeloblast right now because I'm teaching you myeloid neoplasia. So from myeloblast, promyelocyte, myelocyte, metamyelocyte, band form, neutrophil, eosinophil, basophil, and monocyte are formed like this, right? Now, let me first talk about CML. What was happening in CML? In CML, all these precursors were coming in the blood. That is CML, garden party appearance. Now I am teaching you AML. In AML, only myeloblast will come in blood. Only myeloblast will come in blood, not everyone. Only the blast will come in blood. That is the first difference. So that is a school uniform appearance. In school, everyone is in uniform. Everyone is homogeneous, right? So only myeloblast, only one type of cell, everyone is myeloblast. But here it was garden party appearance. So learn the appearance. AML, CML. AML uniform appearance and CML garden party appearance. In AML, only one cell is coming from the bone marrow to the blast, that is myeloblast. And in CML, multiple cells are coming. Give me a thumbs up if you got it. That is the first difference. The second difference, after coming in the blood in CML, all the cells remain in blood only. So CML is always a leukemia. But in AML, after myeloblasts coming in the blood, they will infiltrate in solid organs also. So AML will convert into lymphoma. So solid masses will be formed in organs also in AML, but not in CML. So these are the two differences between AML and CML. I hope you got it. So what is the definition of AML? Now you tell me. It is infiltration of malignant myeloid cells, that is blast. So malignant myeloid cells, blast, first come in the blood and then enter into the bone marrow and other solid tissue. So that is the definition of AML. Have you got it? Kindly give me a thumbs up. Someone, are you listening me? Am I live? Can you see me? Can you hear me? Give me a thumbs up. Let me see. Yes, I can see your chat. Okay. So let me move ahead. So that is the definition. So after definition, the age. Age is here also, it is on an average takes place at 50 years. So 50 years is the median age. Coming on the pathogenesis. Here, what is the pathogenesis? What was the pathogenesis in CML? And now I am teaching you the pathogenesis in AML. In CML also mutation is there. In AML also mutation is there. In CML, the mutation is translocation between 9 and 22. Am I right? In AML, the translocation takes place between different genes. It can be 15 and 17. The translocation between 15 and 17. It can be 15, 17. It can be 8, 21. Right? These are the two translocation and one is inversion of 16. So what are the three possibilities? Either translocation between 15 and 17 or translocation between 8 and 21 or inversion of 16. These two are translocation. On chromosome number 16, one of the gene comes out and get inverted. That is inversion. So these are the three translocation which results in AML. Give me a thumbs up. Come on. Can you see? So have you understood the differences between the mutations or pathogenesis in CML and in AML? In CML, it is translocation always, and it is always 922. In AML, three possibilities are there. Two are translocation, one is inversion. If it is translocation, the first translocation is 821. The second translocation is 1517 and inversion of gene 16. So that is the type of translocations and inversions, that is pathogenesis you can see. Here I have told you the name of the genes also. The name of the gene here is ABL, BCR, right? Here don't learn the name of the genes. Specific genes are there which get translocated from here to there. So that is the translocation. You have to learn exact translocation for your MCQs, right? So shall we move ahead? So that is the pathogenesis. Coming on classification. CML don't have any classification. The AML is of 8 type. What is the 8 type of AML? Starting from M0. M0 to M7. M0 is also a type. M0, M1, M2, M3, M4, M5, M6, M7. So total 8 types are there. And this is known as FAB classification. French, American, British. French, American, British classification. The 8 types of AML in front of you. Now you have to learn their names. Their names are very peculiar and you have to learn it. M0 is minimally differentiated. It is minimally differentiated or undifferentiated you can say. M1 and M2 both are AML. M1 is without maturation and M2 is with maturation. So minimally differentiated, without maturation, with maturation. We are done till M0, M1, M2. M3 is promyelocytic leukemia. M4 is myelomonocytic. This one is promyelocytic, this one is myelomonocytic, and then monocytic. So see M3, M4, M5. So promyelocytic leukemia, myelomonocytic leukemia, and monocytic leukemia. M3, M4, M5. M6 is erythroleukemia. And M7 is megakaryocytic leukemia. Erythro matlab RBC, megakaryo matlab platelet. So have you got it? So shall I write? Can you help me in writing the names? M0, M1, M2, M3, M4, M5, M6, M7. I tried to simplify. So tell me the answers. Who will tell me the answers? What is M0? M0 is AML with minimal differentiation. Minimal differentiation, right? M1, M2 are AML. M1 is without maturation and M2 is with maturation. So without and with maturation. We are done till here. Now let's continue. Let's continue. M3, M4, M5. What is it? So one is promyelocytic leukemia, M3, then myelomonocytic leukemia, M4, then monocytic leukemia, acute promyelocytic leukemia, acute myelomonocytic leukemia, acute monocytic leukemia. You can make the names, right? Acute erythrocytic leukemia, acute megakaryocytic leukemia. I guess I am crystal clear in the concept. From M3 onwards, learn like this. M1, M2, M3, you can learn like this. So total 8 types. Have you got it? Naman Kumar, have you got it? Everyone give me a thumbs up. That is the classification. That is the classification. So we have seen the classification. Now let me tell you specific feature for each type, right? M0. In M0, there will be no iron rod. Iron rod is negative only in M0. And rest all of them iron rods are positive. And iron rods, you know what are iron rods? Iron rods are the rod-like material present in the myeloblast. They are maximum in M3 and they are negative in M0, right? And rest all have iron rod. I have told you 3 translocations now. So out of the 3 translocation, M2 have 821 translocation. M3 have 1517 translocation. And M4 have inversion 16 translocation. Learn their other names also if you can. It will be better if you learn their other names. M4 is also known as Nageli type. M5 is also known as Schilling type. M6 is also known as D. Gulimos type. So learn the other name of M4, M5 and M6. You never know question is coming on what name, right? You never know. So that is the important points you should know. So what important points I have told you? So M0, M1, M2, M3, M4, M5, M6, M7. Right? Let me write the important points. In M0, iron rods are negative. And in M3, iron rods are maximum. And rest all iron rods are positive. That is about iron rod I have told you. After that, I have told you the translocation, the important translocations. So important translocation M2, M3, M4. In M2, it is 821 translocation. In M3, it is 1517 translocation. And in M4, it is inversion 16. So learn the name of the translocation. I have told you. I have told you about the iron rods. Few specific points are there. I will tell you later on. So introduction is done. Age is done. Pathogenesis is done. Classification is done. Let's come on clinical features of AML. So as I have told you how AML differs from CML. In AML, blast first come in the blood and from the blood blast moves to various organs. Have I told this? So the myeloblast from the blood from the bone marrow. First, they are coming in blood, causing leukemia, and then blast enters in various solid organs. So, entering in solid organ is unique, which was not there in CML. Yes or no? So, here, apart from anemia, thrombocytopenia, and infections, the patient have organ infiltration symptoms also. So, let me tell you the clinical features. These clinical features are common with CML. So, anemia occurs in both CML and AML because the marrow is replaced by the blast. Bleeding manifestations are common because of thrombocytopenia. Infections are common, right? Because the mature WBCs are less. But organ infiltration will be unique for AML, which was not there in CML. So the blast can enter in the bones. So bones will have pain and tenderness. The blast can enter in the lymph nodes. So patient can have lymphoadenopathy. The blast can enter in the spleen. The patient can have splenomegaly. The blast can enter in the liver. Patient can have hepatomegaly. The blast can enter in the kidney, causing kidney enlargement and failure. The blast can enter in the gums of the teeth. You know gums of the teeth. Can you see gum hypertrophy is very typical. It is a very important MCQ. It occurs in M4 and M5 type. It is a very important MCQ. M4 is myelomonocytic and M5 is monocytic. Give me a thumbs up. Have you got it? Apart from it, the blast can enter in the skin or orbit. When the blast enters in skin or orbit, it is known as chloroma. See, it is entering in the skin. So skin have a blast. This is a nodule. It is known as chloroma. It can enter in the orbit also. So these are chloromas. Chloromas are there, and blast can enter in the meninges, causing meningeal involvement. So blast can enter in various organs. So you can see hepatomegaly, you can see splenomegaly, renal failure, gum hypertrophy, skin nodule, orbit nodule, meninges involvement. In the skin, it is known as chloromas. Give me a thumbs up. Coming on the lab diagnosis. What you will see in the blood picture? Again, the same thing. What you will see in the blood picture? Of course, RBCs will be less, anemia will be there. Of course, platelet will be less, thrombocytopenia will be there. What about WBC? In WBC, only one cell. It is school uniform appearance, not garden party appearance. Only one type of cell, myeloblast. Myeloblast with iron rod. Can you see these all cells are myeloblast? Can you appreciate all these cells are myeloblast? Myeloblast. You can appreciate iron rod in few of them. You can appreciate all these cells are myeloblast. This is the iron rod. You can see all these cells are iron rod. All these cells are myeloblast. It is uniform appearance. It is not garden party appearance like some of them are promyelocyte, myelocyte, metamyelocyte, band form. No, all of them are myeloblast. Can you appreciate? So these all are myeloblast. Have some of them have iron rods. So myeloblast with iron rod, only one appearance. You see, myeloblast with the iron rod is known as Faggot cell. I have told you initially also. It is a Faggot cell. So you can see the iron rods in the cytoplasm. Appreciate the iron rods. Appreciate the iron rods everywhere. All the cells are same looking. All the cells, all of them are myeloblast. Give me a thumbs up. Appreciate iron rod everywhere. So I have shown you many images of the blood picture. Coming on bone marrow. What you will find in bone marrow? In the bone marrow, cellularity will be increased. Of course, myeloid hyperplasia will be there, and more than 20% of the cells in the marrow are the blast. Right? So that is the bone marrow picture. RBCs will be reduced erythropoiesis, platelet will be reduced megakaryocytes. So blood picture done, bone marrow picture done. In the cytogenetics, you will get the exact mutation. Either translocation 1517 or translocation 821 or inversion 16, whatever. That is the cytogenetics. Immunophenotyping, you can skip, not really important. Coming on cytochemistry. In the cytochemistry, you have to learn the special stain. The name of the special stain. Here, the name of the special stain is MPO, myeloperoxide stain. It will be positive. MPO is positive in all except M0. Except M0, that is negative, and it is maximum in M3. Otherwise, MPO is always positive. Sudan black is always positive, and NSC is positive in M4, M5. So these are the three stains that you have to perform. It is negative for PAS and negative for acid phosphatase. These two will be positive in ALL, right? That is the immunohistochemistry or cytochemistry or other investigation. It's okay. We are done. So revision of the types may important points are that M2 is the commonest, right? M3 may there are chances of DIC. M7 is the AML, which is common in Down syndrome, right? Faggot cells are maximum in M3. That is, iron rod are maximum in M3. And negative, it will be negative. Iron rod are negative in M0. That's why MPU negative in M0. You got my point. So these are the important points in sub pe MCQs hai previous year question papers mein. So you have to learn these important points. So we are done with the types. Now coming last on the treatment and prognosis of AML. What is the treatment? Of course, for anemia, give blood. For hemorrhage, give platelet concentration. That is supportive treatment. There is no targeted therapy available. You have to give chemotherapy. In the chemotherapy, 3 drugs are given. So cytosine arabinocyte is given, anthracyclines is given, and 6-thioguanine. That is the chemotherapy given. But in M3, in which DIC is very common, a special drug is given, that is tretinoin or retinoic acid. So that is the chemotherapy. Bone marrow transplant, if donor is available, HLA matched donor is available, you can do in young age, not in old age. The last is the prognostic factors. You have to learn the prognostic factors. In CML also, I told you 2 index, Sokal index and Hayesford index, and 5 prognostic factor. Here there is no index, but you have to learn what are good prognostic factors, what are bad. Many questions come on the prognostic factor. I will show you in MCQs in the form of the polls. If the age of the patient is young, less than 40 years, it is good. If the patient is very the age is child, less than 2 year or more than 55, both are bad. So patient less than 40 is good, but less than 2 year and more than 55, both are bad. M2, M3, M4 are good, but remaining one, that is M0, M6, M7 are bad. M2, M3, M4 are good. M0, M6, M7 are bad. Blast with iron rod are good, right? Without iron rod are bad, right? see the three type of translocation mutation, that is 1517 which occur in M3, 821 which occur in M2, and inversion 16 that occur in M4. These are good. That's why M2, M3, M4 are good, because their translocations mutations are good. But deletion of 5 and 5 and 7, they occur in these form. It is bad. It is bad. So you have seen what is good, what is bad, right? So we are done with this. Moving to the next type. Moving to the next type, that is ALL. Shall I continue with ALL? Are you people there? Shall we continue with ALL? Let me first revise CML and AML in a comparative manner. Then we will move on ALL and CLL. Right, the next two types. Let me first continue with CML and AML. In CML and AML, let me first continue it. So introduction, what is the definition of each of them? In CML, it is increased WBC count with all premature forms. In AML, it is the blast in the blood which infiltrate the organ. That is the definition. See, age here is more than 50 here. It is around 50 here. It is more or less same. Coming on the pathogenesis. Here pathogenesis is only one 922. Here three pathogenesis are given. Either 821 or 1517, that is the translocation, or inversion 16. Right? So that is, or learn two more. It is 5q or 7q per deletion. So two are translocation, one is inversion, two are deletions. So these are the pathogenesis. Coming on classification. In CML, there is no classification, but three phases are there: chronic, accelerated, and blast. In AML, there is proper classification, the FACT classification, from M0, M1, 2, 3, 4, 5, 6, 7. You know their names also. I have told you the names also. Clinical features are more or less same. Anemia is common in both of them. Thrombocytopenia common in both of them. Infections common in both of them. But in AML, organ filtration is a unique feature. So it can infiltrate in bone, liver, spleen, kidney, in the skin forming chloromas, in the orbit, in the meninges. That is unique in AML. Right. Lab diagnosis, I have told you, the blood picture of both of them is the most important finding. So blood picture in CML shows garden party appearance. Everyone will be there. But in AML, only uniform appearance, that is only myeloblast will be there. Treatment for CML, imatinib is available. For AML, targeted therapy is not available, so go with chemotherapy. And bone marrow transplant is an option for both of them. Prognosis, different indexes are there. We have discussed the prognostic factors. So please write in a comparative manner whatever theory I have given you. It will become fun for you to understand the leukemias. Everyone give me a thumbs up. Shall I move ahead to the next ALL? Are you people with me? So before that, we will be doing some questions of AML. So this is the first question. All of the following have poor prognostic factors except. Which one is good? Which one is good? All of them are poor. All of them are poor except one, which is good. Except one, which is good. Which one is good? I've told you the prognostic factors. So you can see the four options are in front of you. Does anyone want to participate? Inversion 16, is it good or bad? Inversion 16, this one is good. But complex karyotype is bad prognosis. M7 type is bad, and deletion 7q is also bad. I will show you here in the prognostic factors. So you can see in the prognostic factors, we have discussed these prognostic factors. Just a second, let me erase it and come back. So, okay. In the prognostic factors, you can see that inversion 16 is good, right? But 7q is bad, right? M7 is bad, right? And complex karyotype is bad. So remaining three options are bad. Only one is good, that is inversion 16. So come on the question back. Now see the options. So inversion 16 is good, remaining are bad. So you have to learn the prognostic factors very judiciously. So correct answer here is A. Moving to the next question. NSC is positive in all of the following categories except, I told you NSC is a stain that is positive in M3, M4 and M5, not in M6. Right? So you have to learn about the NSC stain. Right? Okay, I'm leaving the questions. You can do it by yourself based on the prognostic factors, and the questions are really very easy. Right? Let me skip the questions and come on lymphoid leukemia. If I do the questions, I will not be able to take the theory. So let me start the lymphoid leukemia. I'm starting lymphoid leukemia. I am starting lymphoid leukemia. Shall I start? So what is the difference here? So again, the same diagram. अब तक तो सबको याद हो गया होगा. This is the bone marrow. This is the first cell in the bone marrow, hematopoietic stem cell. These are the two type of blast, myeloblast and lymphoblast. Right? This is the blood vessel, and these are the organs, solid organs, liver, spleen, lymph node. Right? Till now, myeloblast was coming in the blood. So it was myeloid leukemia. Only myeloblast was coming. It is AML. Along with myeloblast, all the precursors are coming. That is promyelocyte, myelocyte, metamyelocyte, band form, neutrophil, eosinophil, basophil. Everything is coming. If everything is coming, it is known as CML. So basically, in AML and CML, either only myeloblast or along with myeloblast, everyone else is coming. That is CML, AML done. Now coming on lymphoid malignancies. In lymphoid malignancies, if lymphoblast is coming, only lymphoblast is coming, it is known as ALL. So let's start ALL. You got the basic difference. So I'm starting the lymphoid neoplasm. I'm starting the ALL. So what is ALL? ALL is acute lymphoblastic leukemia. Here the lymphoblast, the precursor of the lymphocyte, B and T lymphocyte, that will come in the blood. You can see the diagram. This is lymphoblast. This is pro-lymphocyte. This is lymphocyte. So basically lymphoblast is coming in the blood. Here, lymphoblast. It is of two types, pre-B cell ALL or T cell ALL. Or rather, I will tell you the FAP classification. Yeah, ALL occurs in children. So see, mind the age. ALL occurs in 3 to 5 years of children. Most commonly, it occurs in children 3 to 5 years of age. ALL occurs in children. ALL occurs in children. So we are done with introduction. We are done with age, pathogenesis. Coming on the classification, coming on the pathogenesis. Here also pathogenesis is 922. It is same as that of CML, right? So here also same story is there. On chromosome number 9, ABL is present. On chromosome number 22, BCR is present. Normally they are present alone, so they are doing their job. But during translocation, the ABL from 9 get translocated to 22. On 22, BCR is already present. So fusion gene is formed. That is ABL BCR fusion gene is formed on 22. On chromosome number 22, ABL BCR fusion gene. You can see ABL BCR fusion gene is formed. And that's lead to uncontrolled mitosis of the lymphoblast. This time mutation is not taking place in myeloblast. This time mutation is taking place in lymphoblast. And that leads to uncontrolled mitosis, and that leads to ALL, right? But what is the difference between the two type of translocation then? There are two type of translocation, 922 translocation, ABL BCR translocation. In CML, the fusion gene which is formed, it is 210 kilodalton. But in ALL, the fusion gene which is formed is 190 kilodalton. So based on the size of the fusion gene, you have to decide the type of the translocation. So please learn it is 210 kilodalton and 109 kilodalton, right? So that is the thing. Everyone give me a thumbs up. You got my point? So that is the thing. Coming on the FAP classification of ALL. In the FAP classification of ALL, three types are there: L1, L2, L3. In L1, you can see L1, L2, L3. L1 is the most common, having best prognosis. L3 is the rarest with the worst prognosis. So who is common, who is best, who is rare, who is worst, you have to learn that. So L1 is the common with best prognosis. L3 is the rare with worst prognosis. So we are done with classification also. Moving to the clinical features. Clinical features are same. Anemia will be there in all leukemias. Bleeding disorders will be there in all leukemias. Infections will be there in all leukemias due to bone marrow failure. But here also organ transplant is there. Like AML, the blast here also enter in different organs and causing organ infiltration. So here organs are specific. So bone में तो दोनों infiltrate करते हैं. AML also, ALL also. Lymph nodes में भी I guess दोनों infiltrate करते हैं. But mediastinum, in the mediastinum airway, it is only T cell ALL which infiltrates. It is very peculiar. CNS में infiltration is more common. In the testes of the male, it is more common, right? So lab diagnosis, you can understand in the blood you will find only one cell, school uniform appearance. But this time the cell is lymphoblast, not myeloblast. So anemia is there, thrombocytopenia is there, right? And the cells are only one cell, that is lymphoblast. All these cells are lymphoblast. Can you see? All these cells are lymphoblast. Can we move further? All these cells are lymphoblast. All these cells are lymphoblast without iron rod. You can appreciate the cytoplasm is scanty. The nucleus is having fine chromatin without nucleoli. Right? You can see all the cells are lymphoblast without iron rod. All the cells are lymphoblast. So same picture. So it's school uniform appearance. They are lymphoblast. I hardly see any cytoplasm at the rim. They are lymphoblast and no iron rod. None of them have iron rod. So these are the features of lymphoblasts. In the cytogenetics, in the bone marrow examination, of course, more than 30% of the blast in the bone marrow will be the blast. In the cytogenetics, specific 922 chromosome 922 translocation will be there. In the cytochemistry, no, cytochemistry is opposite. Here PAS and acid phosphatase will be positive, but MPO negative, Sudan black negative, and NSA negative. So these three were positive in AML, myeloblast, and these two are positive in ALL lymphoblast. So you have to be specific for cytochemistry, right? Okay. So cytogenetics is 922 chromosome. That is a lab diagnosis. After lab diagnosis, treatment. Treatment here also for anemia, blood, and for hemorrhage, it is platelet and chemotherapy is given. But the chemotherapy drugs are different. It is vincristine, prednisolone, anthracyclines, and SL-aspergillase. These are the chemotherapy drugs along with bone marrow transplantation. Bone marrow transplantation can also be possible if HLA matched donor is available. The last is prognosis. Many questions come on prognostic factors. What are good, what are bad. So look at the age. If the age is 2 to 10 years, it is good. If the age is less than 1 year, it is bad. Female's mate is good, male mate is bad. So gender is also a prognostic factor. L1 is good, L2, L3 is bad. That is the type. If the blast count is less than 1 lakh, it's good. If it is more than 1 lakh, it's bad. The B type is good, the T type is bad. Right? If the chromosomes have hyperploidy, it's good. If it is pseudoploidy or Philadelphia chromosome, it's bad. Right? So see the prognostic factors, and that's all about it. You got my point? So we have learned AML and ALL. In AML, myeloblast appear in the blood. In ALL, lymphoblast appear in the blood. So we have seen the difference. These all are myeloblast having iron rod. These all are lymphoblast. So please appreciate. So we are done with AML also, ALL also. Everyone give me a thumbs up. Everyone. So in CML, along with myeloblast, promyelocyte, myelocyte, metamyelocyte, band form, neutrophil, eosinophil, basophil, everything is coming. In myeloblast, only myeloblast is coming. In AML. In ALL, only lymphoblast is coming. Right? What about the last CLL? None of the blast will come. Still, it is a leukemia. Here in CLL, what's the full form of CLL? CLL is known as chronic lymphocytic leukemia. It is also known as small lymphocytic leukemia, SLL, CLL or SLL. So it is the tumor of mature small B lymphocytes. It is the mature B lymphocytes which come in the blood. So blast will not come in blood. There is no mitosis or uncontrolled mitosis in the blast. Here mature lymphocyte will come. So you should ask me a question, ma'am, how it become a leukemia? Mature lymphocyte is present in normal healthy individual also. But what is the normal percentage of lymphocyte in normal healthy individual? It is 30 to 40%, not more than that. Here more than 90% of the cells will be mature lymphocyte, number one. And these mature lymphocytes are abnormal. They are very fragile. They are very fragile. It occurs in middle or older age group, that is more than 50 years. So pathogenesis here is, there are many you have to learn. Either the deletion of 13, 11, 17 or trisomy of 12. So 11, 13 and 17. In तीनों का deletion, that is monosomy, and trisomy of 12. You have to learn. You have to learn. 13 is good, right? 13 is good. The deletion of the 13 is most common and it is good prognostic. So that is the pathogenesis, right? So 11, 13, 17 ka deletion and 12 ka trisomy. That is the pathogenesis. You have to be peculiar about the pathogenesis of all, right? Clinical features, these are same. Everyone knows anemia, bleeding, infections, right? Apart from it, यहाँ पे lymphoadenopathy, hepatomegaly and splenomegaly will be there. Lab diagnosis में, blood picture में, here you will get all the cells as mature lymphocytes. These all cells are mature lymphocytes, but they are very fragile. So they will burst. While making the slide, this is a slide. We take one drop of blood here. We are taking a spreader. You know, spreader slide at 45 degree. So whenever we are spreading, many of the lymphocytes will burst. So bursted lymphocyte is known as smudge cell or basket cell. These are smudge or basket cell. So what is smudge cell? This is a smudge or basket cell. Smudge cell is the bursted lymphocyte. So these all are lymphocytes, and we found a smudge or bursted lymphocyte. Here these all are lymphocytes, and this one is the bursted one. The bursted one is the smudge cell. Can you see these all are lymphocytes? Please appreciate these all are lymphocytes. And you can see the bursted lymphocyte is a smudge cell. It is the smudge cell. It is the smudge cell. You got my point? These are the smudge cell along with lymphocytes. These are the smudge cells. You got it. That is the bursted lymphocytes. The smudge cells, that is the bursted. The smudge one. So smudge is the bursted. So smudge is the artifact. That is not a cell. It is formed due to the bursting of the mature lymphocyte. So that's all about the and there is no treatment for CLL. The treatment is palliative and symptomatic, and chemotherapy drugs can be tried. So we are done with the 4 type of leukemia. Does anyone have any doubt in that? Anyone have any doubt in that? The 4 type of leukemias are CML, AML, ALL and CLL. So 4 type of leukemia. Can you tell me the age of all 4? The age of all 4, it occurs in more than 50, it occurs nearly 50, it occurs in 3 to 6 years of age in children, and it also occurs more than 60 or 70 in old age. So everyone, all of them are in adult except ALL, which is in children. That is about the age. Now the most important is the pathogenesis. Here the pathogenesis is 922 translocation. Here also it is 922 translocation. So here also ABL BCR fusion is formed. Here also ABL BCR fusion is formed. But here the size is 210 kilodalton and here the size is 180 kilodalton. You have to be sure about the size, right? That is how much kilodalton is there. So 922 translocation is there. What about AML? Two different translocations are there. Either 821 or 1517 or inversion 16, right? Or 5q or 7q per deletion. So these are the five type of mutations are there. What about CLL? Either 11 or 13 or 17 ka deletion or 12 ki trisomy. Which is the best? The best is 13, right? Best prognosis. So we have discussed the pathogenesis, that is mutations in each of them. So be sure about the mutations. You have to learn it. You have to learn it. After that, coming on the blood picture. The most important is the lab diagnosis and the blood picture. So blood picture here only myeloblast, here only lymphoblast. Both of them are uniform appearance. In CML, along with myeloblast, you will get promyelocyte, myelocyte, metamyelocyte, band form, neutrophil, eosinophil, basophil, everything. So this is garden party appearance. On the contrary, in CLL, you will get mature lymphocyte, no blast. You will get mature lymphocytes along with smudge or basket cells, which are the bursted lymphocytes due to increased fragility. They are very weak, cell membrane is there. So that is the, you can see that is the blood picture of each of them. So I have told you the definition, the age, the pathogenesis, classification you have to learn. CML में no classification, CLL में no classification. In AML, 8 types are there, M0 to M7. In ALL, 3 types are there, L1, L2, L3. Both are FACT classification, French, American, British classification. Clinical features you already know. Lab diagnosis, blood picture is in front of you. Treatment may the targeted therapy is available only for CML. Okay, I'm sorry. It is only available for the CML, the targeted one. So we are done with the 4 type of leukemias. Okay, just a second. What is happening? Yeah. So we are done with the 4 type of leukemias. Does anyone have any doubt in that? So let's revise. Let's revise. So in the myeloid leukemia, myeloblast will come in the blood. In lymphoid leukemia, lymphoblast will come in the blood. So CML may, I've told you it is garden party appearance. So you can see all the cells are there. All the cells are there. In AML, only one cell is there. That is myeloblast with iron rod. Right. In ALL, only one cell is there. That is lymphoblast without iron rod. That is lymphoblast without iron rod. In CLL, no blast. In CLL, the mature lymphocyte along with the smudge cells. That is the summary. Everyone give me a thumbs up. So I would like to stop here. I have covered all the leukemias. So I will arrange a separate session for the lymphoma in which I will cover Hodgkin's and non-Hodgkin's lymphoma. So thank you very much for giving your precious time to me. I hope you have learned the session. There are few announcements for you. Unacademy is launching few new batches for the NEET PG 2023 preparations. So if you want to attend the sessions, the batches, the live classes in this batch, you have to purchase the subscription. There is a new batch for the repeaters also. Now iconic prices are increasing soon. So if you want to take subscription, take it now. In the next few days, the price hike will be there. So that is an announcement from the team. Right. On Unacademy, 5 type of subscriptions are available. Plus subscription, you will get only Unacademy. Iconic, along with Unacademy, you will get Prep Ladder also. In light subscription, you will get test series. In Profma subscription, you will get anatomy, biochemistry, and physiology. In UPSC subscription, you will get UPSC preparation. You can see various plans of various durations along with various prices. Longer the duration, cheaper it is. So go with a longer plan if you wish. If you require, if you are a first prop, second prop student, you can go as long as 4 year, 3 year, 2 year. It will be per month wise cheap to you, right? But if you are not sure, you can take as small as 3-month plan also for a trial basis. Whatever plan you are thinking of purchasing, before payment, apply my code. My code is Sachdev. That is my surname, Sachdev. I am Dr. Priyanka Sachdev. Sachdev 10 is the code. Thank you very much for being with me. Study hard. Bye bye. Good night.